Welcome everyone to Pulmonology Read Aloud, your one-stop solution for all the latest evidence in pulmonology. Today, I am beginning a 3-episode masterclass on the brand new 2026 AHA ACC Pulmonary Embolism Guidelines. I will be following a different approach in this episode. Instead of reading the recommendations to you directly, we are going to approach this guideline exactly as we would do in clinical practice through real patients, clinical reasoning, and the guideline. By the end of this session today, you will know when imaging is really necessary and how to interpret the various tests and clinical probabilities. So let's get started with episode 1 of 2026 Pulmonary Embolism Guidelines. Today we'll talk about ruling out pulmonary embolism before a CT scan. So let's get started. Meet my patient, a 58-year-old woman who had a sudden pleuritic chest pain. She was dyspneic for the last 4 hours. Her heart rate at presentation is 108, BP of 124/76. She has a good saturation on room air and the initial x-ray is normal. Now this patient does not have venous thromboembolism. There is no surgical history recently. She doesn't have cancer, hemopsis, or any leg swelling. Remember this patient, Mrs. Mehta, because we are going to be using this case for understanding the guidelines. So now, imagine you are the admitting physician. Now, this patient certainly has a very strong history based differential of pulmonary embolism. The acute onset pleuritic chest pain with breathlessness with a normal chest x ray and no past medical history, no history of an infection, just a severe acute chest pain. But does this patient need a CT pulmonary angiogram immediately? Do we need to stop and pause and follow a protocol that gives us more reliability before going ahead and doing a scan right away? Should we estimate a clinical probability? Let's keep this answer in our mind and we'll return to her throughout today's video. So, why does this guideline paper matter? Now, this 2026 guideline paper is a very elaborate 75-page document, and it has been endorsed by not only the American Health Association, the American College of Chest Physician, Cardiology, and multiple other societies. So, it's a joint guideline which talks about how one should approach a patient of acute pulmonary embolism. It gives us the importance of estimating a clinical probability before going ahead and doing a particular investigation. It helps us understand a better use of the various probability scores that exist. It helps us apply D-dimer much better than previous times, and it helps us use neural algorithms like the EARS algorithm to estimate our next step. With that, one can choose the correct imaging and we can then understand how to treat our patient based on the clinical categories. So, this is what this guideline offers and is much refined as compared to the previous years. The key takeaways from this new guideline are the new 5 pulmonary embolism clinical categories. It also gives us more information about admission, where to admit the patient, the discharge criteria. It talks about the PERT committee. It talks about preference of anticoagulation and how to avoid or prevent recurrence and reduce the risk and add follow ups. So, this changes how we classify PE patients, it changes our diagnostic pathway and our long term follow up. So, this de novo guideline provides comprehensive recommendations for managing adult patients more than 18 years of age with acute pulmonary embolism. And if I have to say, the main feature which enhances the precision of this guideline is how it has divided the severity, the prognosis, and the decision making therapeutically. So, for spoilers, the 10 top take home messages from this guideline include categories A to E for acute pulmonary embolism. It includes managing patients who are asymptomatic to be safely discharged home if they are not in the severity grade. Early hospital discharge for patients with acute PE who are symptomatic but have a low clinical severity score. Treating patients who are symptomatic with high clinical severity scores and elevated biomarkers or signs of right ventricular dysfunction or cardiopulmonary failure in the hospital. Using advanced therapies including systemic thrombolysis, catheter based thrombolysis, mechanical thrombectomy, and surgical embolectomy for selected patients based on the category. Developing PE response teams in the hospital to improve care. Also, for patients who require initial parenteral anticoagulant, preferring low molecular weight heparin to unfractionated heparin. Number 8, in patients who have acute PE and eligible for DOAC, giving them preferentially over vitamin K antagonists. Number 9, for patients with first acute PE episode without a major reversible risk factor, continuing anticoagulation beyond the first 3 to 6 months to an extended phase. And lastly, for patients who have acute PE, we should ask them about PE related symptoms and limitations for at least 1 year follow up to rule out chronic thromboembolic pulmonary disease. So, with that, top 10 take home, which summarize the entire document, let's go back to our patient, Mrs. Sharma, and try to approach her with the guideline. So, how should we think about a suspected PE case? It's important to think before you scan. When you are seeing your patient, the guideline stresses that you have to do a clinical assessment first, the symptoms and the examination. With that assessment, you arrive at a pre-test probability. With the pre-test probability is decided whether a D-dimer is relevant, and together the pre-test probability and the D-dimer decide if imaging is needed. So this is the crux of the clinical evaluation of a patient with suspected acute PE. Take some time, pause this video and look at this beautiful flowchart. I'll be spending a lot of time on this flowchart with my patient scenario so that you can understand it much better. So, when we are looking at a patient with symptoms suspicious for acute PE, as I said, it's important, according to this guideline, to do a history and a physical exam and try to look at the probability of our differential for pulmonary embolism. We also quantify the clinical probability using validated tools, which we will be talking about. Based on the probability, we derive low, intermediate, and high probabilities, which then further give us the pathway to include or exclude P as our strong differential, and on the basis of this, perform further testing. So, the guidelines' first recommendation is simple but crucial. Begin with a targeted history. a comprehensive physical examination, and estimate the likelihood of pulmonary embolism. So ask yourself, is there a history of recent surgery, cancer, pregnancy, estrogen therapy, hormonal therapy, immobility, previous surgeries which would have led to immobility, previous thromboembolisms, and leg swelling, specifically unilateral leg swellings? They should immediately raise the suspicion. When you estimate the clinical probability, there will be three common tools that you can utilize. The first tool is the Wells score, the very well known Wells score for pulmonary embolism. The second is the revised Geneva score, which can also be used. And the third one that they mentioned is the PERC or PE rule out criteria. How to use them, where to use them, this is what we'll be discussing next. So, coming to my patient now. If you look at the Wells score says that you should estimate the clinical symptoms of DVT. See if the patient has signs of DVT. Secondly, it also wants us to see if PE is more likely than other diagnoses. Check the heart rate more than 100. Look for immobilization because of a surgery or a fracture within the last 4 weeks, a previous DVT or pulmonary embolism in a history, hemopsis, and cancer. Don't try to memorize the score on the first viewing. Let's understand how we can think through it. Ask yourself, is clinically PE the most likely diagnosis? With this patient scenario, PE could be one of the most likely diagnoses, so that's true. Now, quickly add the remaining variables. Does my patient have signs of DVT? I don't see any mention of signs of DVT in this case scenario. Does my patient have a heart rate above 100? She does. Does my patient have a history of immobilization? No. Previous thromboembolism? No. Hemopsis and cancer? No. So then what is her Wells score? So for this patient, the Wells score turns out to be 4.5. We have given 3 points for a clinical diagnosis, a clinical gestalt that this patient might have PE, and we've given her 1.5 points for heart rate being above 100. So now, does this place her in the PE likely group? So yes, because this patient seems to be clinically more possible to be a case of PE, for us, this patient is in a PE likely group. So we've given her the 4.5 points on the Wells score. If this patient would have presented with fever and a productive cough, then this question of whether PE is more likely than other diagnoses would have been negative. We wouldn't have given the 3 points we have given on this score. And so, in that case, this patient score may have been just 1.5. So, remember, PE more likely than an alternative diagnosis is not based on one single symptom like a pleuritic chest pain or breathlessness. It is your overall clinical judgment after considering the history, the examination, ECG, chest x ray, and all of that that you have done in an emergency setting. If after all of that, pulmonary embolism remains your best explanation for this patient's presentation, you are awarding 3 points. So, this is one important clinical pearl because many of us think that this is the most subjective part of the Wells score, and that is right. It is the only component which depends on clinical judgment and not a fixed value or a finding. And that's also one reason why the revised Geneva score was developed because it removes this subjective element and uses only objective variables. So you can use this as a score, or when you want a more objective assessment, a revised Geneva score can be used. So, PE more likely item should not be triggered only by history but is a clinical gestalt of your judgment that PE may be the most specific diagnosis. Let's move ahead. Let's ask ourselves about the Geneva score, about the PERC, which have been mentioned in the guideline paper. Which one should I actually use? Now, based on the guideline, no single score has been recommended as universally superior. It recognizes multiple validated clinical prediction rules and recommends that you use any validated tool for your pretest probability. So it has discussed all these three scores and has mentioned that in the appropriate clinical context, you can use one. If I talk about PERC, which is PE rule out criteria, they are specifically intended for very low risk patients to avoid unnecessary testing. But when you're talking about estimating the pre-test probability, you will either use a well or a revised Geneva score. So it supports the use of these two more. What does the paper say? It says clinical decision tools like Wells and Geneva Revised and the PERC are frequently used to synthesize history and findings and inform pretest probability. Those tools that incorporate assessment of clinical suspicion of PE with the lab testing are recommended to identify who should undergo diagnostic imaging. So that's how we need to approach. Let's now utilize the revised Geneva score also for this patient and see for ourselves. This patient is definitely less than 65 years with no DVT, no surgery, no cancers, and no low limb pain. No hemopsis, a heart rate more than 95, giving her a score of 5, and no pain and unilateral edema, giving the revised Geneva score as 5 for my patient. So we have a condition where for this patient, the well score is 4.5, which is interpreted as PE likely, and the revised Geneva score is 5, which also gives us an intermediate probability. So for our patient, we have tried using both clinical impression and Wells and clinical impression and revised Geneva score. And what we are getting is that there is a probability that this patient might have pulmonary embolism. Now, notice that these two scores don't use identical categories, but both are indicating that this patient can be considered as a case of pulmonary embolism. So, it's very important not to compare the numbers directly. They are using different scoring systems, but we have to recognize that eventually they are giving us clinical probability. So, which one would you prefer using in your patients? A revised Geneva score or a well score? Let me know in the comment section and we will see what majority are using. So, now this definitely tells us that we cannot stop here. We have to go on to the next part of the diagnostic algorithm in this case. And let's see what does that say. So there is another score, or rather another criteria that have been mentioned in the diagnostic algorithm in the guideline. This is the PERC rule. The PERC rule is mentioned for patients with very low pre-test probability as a rule out strategy. So if you look at the PERC rule for our patient, now PERC rule says that if the age is less than 50, the heart rate is less than 100, the saturations are normal, and with none of those significant histories, you can rule out pulmonary embolism. So assess if a clinical pretest probability is less than 15%, saying a Wells of less than 2, which was not true for our patient. She had an intermediate probability. And then for those who have a very low probability, if all the criteria are met of PERC, the likelihood of PE is low. So no D-dimers and no imaging needed. So what is the role of our next tool now, which is D-dimer? Now there are three doors that every suspected PE patient will enter. One, if there was a very low probability, PERC can help you rule out. Two, if there was a low and intermediate probability, like in my case, then you have to obtain D-dimer, which can also be of various other specificities like the age adjusted threshold, which you should use if your patient is above 50. And then based on D-dimer being negative or positive, you further go on the flowchart. And the high probability patients will go directly to imaging, which CT pulmonary angiogram is as the preferred modality, which we will come to later, and you confirm the diagnosis. So now, after the clinical probability is set, you have to take the patient through one of these three options. So, coming to the second part, now the clinical probability is intermediate for our patient. So, a D dimer is the next logical step. So, the guideline flowchart says perform D dimer testing and assess years criteria. So, we'll come to years criteria, but can a D dimer save us from a CT scan? So, for our patient, Mrs. Mehta, we have looked at the well score, and we now know that her D dimer came out to be 620. You could also use age adjusted D dimer because she's more than 50 years of age. So the age adjustment does not magically make every D dimer negative, but we are trying to look at management in older patients who may have a higher D dimer. So the guideline says that age adjusted D dimer strategies are safe in patients with low or intermediate clinical probability of pulmonary embolism, resulting in less than 2% missed thromboembolisms at 1 to 3 months. So, this comes out of a prospective validation study of more than 3,000 patients where they looked at 3-month failure rate looking at D dimer value in patients above 50 years. So, age adjusted ones should also be looked into. Now, the criteria of age adjustment is just multiply the age by 10, and that becomes your predicted cutoff. So, for our patient who's 58 years, 58 multiplied by 10, 580 is the predicted age adjusted cutoff. What is our measured D dimer here? 620, which is still high. So, that means our patient is still having a high probability of PE, and we must go further in the algorithm. So now we've established that our patient has a positive D dimer. She also has high intermediate probability based on the clinical probability scores. So what should be our next step? Should we not test her? Should we apply years criteria? Should we do a CTP immediately or do a VQ scan? So the guideline clearly mentions that we can use another algorithm called the years algorithm to reduce unnecessary CT scanning. So the years algorithm is only a set of 3 questions. Notice how in intermediate clinical probability, the flowchart mentions using the years criteria and goes on to say that if there are 0 years criteria, the D dimer cutoff is 1000 and PE is excluded. If there are more than 1 year's criteria in that patient, the D dimer cutoff is 500 or the age adjusted threshold, and you can exclude it. And for patients with 0 years criteria and the D dimer being very high, more than 1000, you still do diagnostic imaging. But more than one criteria and D dimer more than 500 or age adjusted threshold being high, you would perform diagnostic imaging. So basically, just to simplify, the years criteria again asks you whether there were clinical signs of DVT, hemoptysis, or was PE the most likely diagnosis when you started off. If the answer to any of it is yes, then you use a D dimer cutoff of 500. If the answer to any of this is no, so there are all are 0, then you use a D dimer cutoff of 1000. So this came out through a year's validation cohort, which showed that all across probability levels, you can use years criteria. So you can re-ask your clinical questions that you had started off before. There was a multi-center randomized non-inferiority trial in Europe that looked at years algorithm incorporating age adjusted D dimer versus age adjusted D dimer alone, and they found out that the years criteria plus age adjusted D dimer approach had low failure rates and better efficiency. So it can be used. please remember that Ear's algorithm has only been tested in patients who were not on therapeutic anticoagulation, because then the history of hemopsis, DVT, and all of that can change. So, Ear's criteria is our next one last final step before choosing imaging. So, for our patient here, the Ear's criteria is 1, and so our D dimer threshold is 500, which is less than what she has had. So we have to go on and proceed to imaging. Let's take another clinical scenario of a patient whose D dimer was 780, but PE was not the most likely diagnosis clinically. Here, because years criteria will be 0, the threshold will be 1000. So, imaging is not recommended and we can exclude PE. So, when you're diagnosing acute pulmonary embolism, you have three situations: very low probability, intermediate or low probability, and high probability. For very low, do the PERC criteria and rule out. For low or intermediate, use D dimer. If it's positive, use Ear's algorithm. Then look at the modified threshold and do imaging if indicated. And if it's a high probability, don't do any of this. Go directly to imaging, confirm, and start treatment. So, coming to one more concept mentioned in the guideline, which is pregnancy adapted years. Now, pregnancy itself increases D dimer. So, pregnancy adapted years algorithm means we are looking at the clinical assessment and presence of pregnancy with modified D dimer threshold to reduce unnecessary imaging. Here, just like the normal years criteria, if one or more of years is present, 500 will be used as a threshold for pregnant females. So, if this was a 28-week pregnant female who was young, 29-year-old, with dyspnea, stable BP, heart rate, no leg swelling, but a D dimer of 820, the measured D dimer would be measured against 500 threshold, because P is a most likely diagnosis and we have to do imaging for this pregnant female. What I want you to understand is that the guideline has mentioned pregnancy adapted years for pregnant females. This does not make it a um, separate tool. It does not give us a separate calculation. It just mentions that pregnancy adapted years has been uh, seen through trials in pregnant females. So while the initial years protocol which was released did not involve pregnant females in the study group, pregnancy adapted years algorithm was validated in an Artemis study, which showed that you can use it to reduce the need of CTPO or VQ scanning in pregnant females while maintaining a very low rate of missing the venous thromboembolism. So the criteria is same, it's just that you can use in pregnant females. So why is it called pregnancy adapted? Because the adaptation is not the threshold, it's just the validation in pregnant females. So here for our patient, we are using years criteria to continue to take a decision of imaging. Now comes the question, the hard one, then which imaging to choose? CTPA, VQ scanning, compression ultrasound of the lower limbs, or an echo. And for that, the recommendations have given us a table with the levels of evidence and the grade of the recommendation. So, they have given us the options of CTPA, VQ scanning, compression ultrasound, with each of them being marked for what exactly would be preferred. Remember, the current standard imaging modality for diagnosis of acute PE will be CTPA, because it's widely accessible, because of its relative cost to what we are getting in return, low radiation exposure, and excellent diagnostic performance. So, the first level of recommendation and the best evidence is for CTPA. Only for patients where CTPA cannot be performed or is not optimal, a VQ scan is allowed as a grade 1 recommendation to be used as an alternative, because it also has an excellent diagnostic yield, especially when you combine it with SPECT. Now, when we talk about other modalities like an echo, they mention that an echo is an inadequate test for diagnosing PE, but it's important to assess RV function for symptomatic patients with confirmed PE. They've also said that when you are using echo, the parameters of right ventricular structure and function have to be assessed and reported properly. And there is a set of measures that must be done and will be discussed. Further, they also say that when you are getting a CTPA done, you should also get the evidence of RV dysfunction in reported in the CTPA when acute pulmonary embolism is confirmed. Regarding the use of venous duplex ultrasound, they mention that it is useful in patients with clinical findings suggestive of DVT or when the confirmation of DVT will influence our management. Routinely evaluating for DVT in all suspected cases of PE is not recommended, but because it does not improve the diagnosis and will only result in increasing healthcare costs. They further say there is no data to support or refute the role of identifying DVT at the time of PE diagnosis as an adjunct to the risk prediction probability rules and the risk stratification. The detailed text, however, says that the only time when you might consider using the ultrasound here would be when you are using, say, catheter directed interventions. So, where those interventions might reduce the risk of post thrombotic syndrome or will influence the decision regarding use of IVC filters. But strictly no benefit and no recommendation in three scenarios. Number one, when you have a suspected P but a negative CTPA and a normal VQ SPECT, there's no role of doing a duplex ultrasound. When you have a suspected P, there's no role of just doing an echo to confirm or refute the diagnosis. And there is no role of doing a CT venography of the IVC to diagnose venous thrombosis in such settings. For reporting findings on diagnostic imaging, as I said, it's very, very important that you do the right numbers and you give the detailed report. So, for echocardiography, remember it is not sufficient to confirm or refute the diagnosis alone. Most patients who have a PE will show RV dysfunction, but you have to record it. The performance of echo to detect PE will improve in patients with hemodynamic compromise, but the specificity is not good. So, it should only be confirmed with the direct PE imaging and not the echo. For transthoracic echo, they have mentioned in the text of the guidelines as a part of evaluation of PE. If you are doing that, then parameters of RV dysfunction and strain should be reported as comprehensively as possible. So, these are the optimal methods of RV dysfunction assessment. Look at this table and it gives you a whole view of what should be in the report. There should be a mention of the RV dimension. So, end diastole from right ventricle, focused apical four chamber view, that should be the way we assess the RV dimension, or the apical four chamber view. The parameter is that the end diastole diameter should be more than 30 millimeters and RV basal EDD should be more than 42 millimeters. Secondly, they should mention about RVTLC. So here again at the end diastolic ratio, you can use to assess the RVLV, apical or subcostal view. The RVLV should be more than 0.9. The third is the TAPSE or tricuspid annular plane systolic excursion. How do we do it? It measures the distance of the systolic excursion of the right ventricle annular segment in centimeters on M mode along a longitudinal plane from a standard apical four chamber view from end diastole to end systole. So the TAPC should be less than 1.6 centimeter to be called abnormal. The tricuspid annular plane systolic excursion. Fourth, Doppler evidence of pulmonary hypertension during Doppler imaging. A pulmonary acceleration time more than 90 milliseconds or presence of an RV atrial gradient of more than 30 will clinch it. And lastly, the tricuspid systolic velocity through a apical or subcostal four-chamber view, it should be more than 2.6 mil per second. So if these parameters are met, then we can assess RV dysfunction, and so an echo report must contain all of these: the RV dimension, RV PON LV, TAPSE, Doppler evidence of pulmonary hypertension, and tricuspid systolic velocity. Now finally, based on all of this, the acute PE clinical categories have to be decided. So now that you've done the imaging, now that you've done the right test and diagnosed the patient, you need to put the patient into one of the 5 clinical categories. And the remainder of this series will revolve around these 5 categories. So, for our patient, in the next episode, we are going to look at where we should be managing this patient based on the risk stratification, whether we should be doing thrombolysis, thrombectomy, how to manage it. But before you watch this episode, the episode 2, just pause, decide how you plan to manage this patient. Are you going to manage it, him or her in the ward or the ICU? Write your answer in the comments, and in the next lecture, we'll compare your decision with the 2026 AHA ACC recommendation. So with that, we will be closing this video and this episode today.